Hello, everyone. My name is Ty Harding. I will be doing the article summary within the condition presentation. I chose Clinical Management of Gender Dysphoria in Children and Adolescents, the Dutch approach. This article discusses the Dutch approach to the clinical management of prepubertal children under the age of 12 and adolescents starting at age 12. There are different approaches and treatment options for children under 12 and as well as children that are 12 and older diagnosed with gender dysphoria. There's a significant detail and statistical evidence provided in the article to justify the need for more attention to the effects of gender dysphoria in children and adolescents. The facts presented are rooted from research gathered from the first specialized gender identity clinic for children and adolescents at Erich University Medical Center in the Netherlands. This gender identity clinic has been recognized as the world leader in the treatment and diagnosis of gender dysphoria among children and adolescents globally. There is no unequivocal etiological factor that determines atypical gender development to date. So it is important to take the perspective of development into account in the diagnosis and treatment of gender dysphoric children. Now I will get into the difference between the children and the adolescents diagnosis and treatment processes. So with children in diagnosis in the Netherlands, gender dysphoria is a dimensional phenomenon and can exist to a greater or lesser degree, depending on the child. Many aspects of the child's functioning are evaluated, such as cognitive levels, psychosocial functioning, and scholastic performance. If any other possible psychopathology is found, the relationship between gender dysphoria and another diagnosis would need intensive investigation. Other psychiatric diagnosis may be unrelated to the gender presentation. However, it will still require attention. Regarding the treatment of children, the Dutch approach to the treatment of GID has therapeutic elements in its approach, but it is not directed at the gender dysphoria itself. The focus of treatment is on the emotional, behavioral, and family problems that may have an impact on the child's condition or functioning. With that being said, parent counseling is highly recommended with an appropriate style of child rearing and advice geared toward dealing with gender dysphoria, and this is sufficient if the child displays no other associated disorders. Individual mental health counseling is also recommended for children that display other non-gender dysphoria related problems. And in summary, there are currently no physical medical interventions that are provided to children before puberty. Adolescents. So when it comes to diagnosis, unlike children, adolescents with gender dysphoric feelings rarely remit. Therefore, the diagnostic approach and process is heavily focused on how to approach treatment. Developing rapport with the adolescents and their families is needed to obtain open and non-judgmental contact during the diagnostic process. Puberty suppression is considered for adolescents that live in a supportive environment and have displayed no serious psychosocial problems that may interfere with the diagnostic assessment itself. All possibilities and impossibilities of potential treatments are discussed with the adolescent and their family, and this helps prevent unrealistic high expectations from the entire process of gender reassignment. Regarding the treatment of adolescents, the Dutch approach looks at it in a holistic fashion. Adolescents that display other associated psychiatric or family problems are actually recommended for some form of psychological treatment. Transitioning begins as the youth starts living in the desired gender role while in parallel with puberty suppression. Physical medical interventions become available at age 16, with some totally reversible and others not. The diagnostic phase is followed by the real life experience in which cross-sex hormones are prescribed, and eventually the subject can undergo full-blown gender reassignment surgery. So, in conclusion, although children and adolescents go through meticulous diagnosis, pubertal children can be considered eligible for physical medical interventions, while non-pubertal children cannot. Physical medical intervention does not rule out psychotherapy or other psychological interventions that go in parallel with gender reassignment, because all functioning and circumstances regarding the individual need continued attention. Although there are significant health risk and potential harm that could be done by physical medical interventions, it is currently understood that holding these interventions can be even more harmful for the adolescent's well-being during their current stage in life and also throughout their adulthood. I hope you found this information useful. Hope everyone has a great day and enjoy the rest of our presentation. Thank you.